Right, so plasma testing for genetic variations can be incredibly helpful in the common scenario of a patient who either doesn't have enough tissue for testing or you have to wait a significant amount of time. So it's very common in my practice for patients to have had a biopsy somewhere else. So we don't actually have access to their tissue immediately. We have to somehow track it down. We have to have it mailed to us. The pathology department has to send out for a tissue block, and then it has to be tested. It may take a number of weeks or a month to really get those results. And the patient really doesn't want to wait that long, or maybe they're sick and they can't wait that long. That's a setting where a liquid biopsy can be extremely helpful. By itself, plasma testing probably can't replace tissue testing. It's extremely reliable. If you find a positive result of a mutation or a gene fusion on plasma testing, you can use that and go right on to treatment. In common mutations like KRAS mutations, where if they have that, you know they likely don't have another actionable mutation, and you can move right on to common systemic therapy, chemotherapy, or immunotherapy. That can be very useful. The thing to remember about plasma testing is that it probably is going to miss about 20% of actual mutations, which means if you get a negative result on a plasma test, you have to still follow through and do the tissue testing, either getting a new biopsy or tracking down that tissue. And that's a scenario where if you have to start treatment again, I would usually just start with chemotherapy alone and not add in a checkpoint inhibitor until you know for certain that that tissue is negative.